from the American Academy of Pediatrics.
2025 has been a tumultuous year for healthcare providers and patients, with cuts to government programs announced almost every week.
AAP President Dr. Sue Kressly is here to help break down what these cuts mean for kids.
I think the moment requires some ferociousness, and I'm up to the challenge, I guess, if anyone is. But I want everyone to come with me on this journey.
Plus, a new study looks at how Medicaid unwinding affected medication dispensing for children and young adults with chronic conditions.
Policymakers really need to do what they can to minimize and perhaps even expand and build upon Medicaid so that all children and young adults with chronic diseases have access to the medications that they need to stay healthy.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about federal cuts to children's health.
As someone who really believes that science and data make us healthier and set up a better future for children, I'm also struggling with all this restructuring of our healthcare ecosystem.
I mean, for the first time in my quarter century of practicing pediatrics, I'm seeing us moving backwards in child health, and fast. I want to take a second to just list some of the cuts, and please feel free to add into this, Joanna. First off, we've already lost tons of expertise in the National Institutes for Health and the Centers for Disease Control and Prevention, the people who know the most about how the government conducts research and promotes public health. Then there are the large centers that focus on asthma and air quality, preventing childhood lead poisoning, and immunizations that are gutted or on their way out.
I took it really hard when the federal government stopped supporting safe sleep for infants, and I know there is a lot of funding uncertainty and cuts for preschool programs like Head Start. My own son goes to a Head Start center, and it's such a phenomenal part of our community and our public school. Plus, the Maternal and Child Health Bureau. It's just so much to navigate and unpack.
Whew, then let's bring in another voice to talk about cuts that will devastate children's health and some of the work she and the AAP are doing now to continue to advocate for children. Let's welcome AAP President and friend of the podcast, Dr. Sue Kressly, back on the show.
Dr. Kressly has been talking a lot in the media about how federal cuts are going to impact children. Sue, welcome back.
Thanks so much for having me. And I wish we were having a more positive conversation, but let's try to figure out how to put some hope in this while we're talking.
Well, if anybody can do it, I know you can. I think right now pediatricians and families are feeling a lot of uncertainty and anxiety about a loss of federal funding for children's health. Is that warranted?
David, I think it is. I think that there is a lot of uncertainty, and we know that uncertainty, anxiety, and chaos really is not good for any of us. And we don't make our best decisions and we don't function optimally in the middle of anxiety and chaos. But whenever there is anxiety and chaos and doubt, we need to find like-minded people who are looking for solutions so that we can work together to minimize that anxiety and give children and, frankly, ourselves as professionals what we really need on a day-to-day basis. And so just the question marks, the commas, the uncertainties is leaving everyone feeling anxious and uncertain, and no human being is their best self amidst chaos, uncertainty, and anxiety. And we know what it really does to children and families. Joanna, you especially know that cortisol in the middle of stress really changes the way we think, the way we operate, and erodes our health and well-being. And when that presents in our clinics, not only is our own well-being impacted, but we are spending so much more time with every visit, even if it's for something simple like a rash. Almost every patient and family have a question about what is happening in my community, what should I be worried about? And there is just underlying fear and uncertainty that is unwarranted and unnecessary and in direct opposition of what we know children and families need.
One of the things we're uncertain about is Medicaid and if funding for that is going to be cut. And this will affect children with chronic conditions, those with disabilities. What is the best way to address concerns from these families when they enter our pediatric offices?
So I want to be clear for our listeners, because I've been hearing from people, well, those are kids on Medicaid and that doesn't impact my family. Or I don't take Medicaid in my clinic, so I'm not really worried about it. Or the Medicaid coverage in my state is only 17%, so that's not really where I'm going to expend my energy. Let's be clear. Medicaid funding is the backbone of the healthcare delivery for pediatrics across the country. And it doesn't matter if you have commercial insurance, Medicaid insurance, whatever plan you have, it is the delivery of health care for children that totally depends on Medicaid. Take children's hospitals, for example. Significant amount of payments in some places, more than 60%, are based on Medicaid payments. So if Medicaid payments go down to children's hospitals are going to have to make some hard decisions. Do we scale back our program for asthma? Do we scale back our multidisciplinary clinic for kids with cerebral palsy? Do we cut our resources for our community links for transportation for kids who've been impacted by serious injuries or accidents? So once those children's hospitals start to pare back and have to make tough decisions about paring back on what they're going to keep and what they're going to pare back or get rid of, every single child in every community will lose access to the care that they may need today or tomorrow. And again, I've been saying to policymakers, if you have kids or grandkids, your kids and grandkids are going to be impacted by these impacts, not just the kids who are covered by Medicaid. And this is worst in rural communities, where we're already seeing closures of pediatric beds, both physical health and mental health beds across the country. In the middle of a mental health crisis for children and adolescents, we are threatening mental health care delivery for children across the country, and especially in under-resourced and rural areas.
Sue, as you know, I trained in adult and pediatric medicine, and I think there's a difference that maybe not all of our policymakers or families understand, which is that in adult medicine, there are hospitals that are public hospitals where people who need support may go, and then there are these other hospitals that are better resourced. Our world in pediatrics is very different than that. Can you talk about how all children rely on children's hospitals?
Well, and all children really depend on Medicaid to be strong. It doesn't matter Medicaid insurance or non-Medicaid. And I'll try to simplify this. Pediatric expertise is really collectively supported in children's hospitals that then reach to communities. And so that if you're a child 3 hours away from your pediatric community and your pediatrician sees you for something they think might be cancer or a tumor or a concussion that's not getting better, they're going to reach back to their experts at the children's hospital to make sure that you get the most appropriate care. Some of that will maybe be in the community, but some of it may be extensions through telehealth or having to see someone at the children's hospital or be part of research protocols to advance, for example, pediatric cancer. If we erode the Medicaid infrastructure in the children's hospitals are going to have to make hard budget decisions about what will be cut. And inevitably, some of those programs that will be cut also will extend to your community wherever you live with your children, and they will lose the access to the experts in pediatric healthcare when they need it most. And we need the experts to be there with extensions throughout every community so that every child can be supported no matter what happens to them and no matter where they live. So let's start with the level set that this isn't just those covered by Medicaid. It's every child because the healthcare delivery of pediatric care depends on Medicaid and strong Medicaid payment. So what do we say to patients? So first of all, I always go back to empathy and really connecting with families. And what I think we need to say to families is, we're with you. No matter where this journey takes us, no matter how hard it is, we will take this journey with you. But I also am encouraging them to speak up. It is not us. For too long, I think, in medicine, we've been talking to each other and to ourselves. It's time that we really create a movement in the public space so that everyone who realizes that while kids are 22% of the population, they're 100% of the future in every community. And every community needs to raise their voice and say, no, we will not do this. The kids are our future. We will invest in them. And we have to save Medicaid. And in fact, I thought I would be spending my presidency year talking about making the value statement for investing more in kids. And instead, I'm just trying to make sure that we don't go backwards. However, never waste a crisis. We have now more people interested in understanding how Medicaid works, and we need to bring both the data that we have about how many kids are covered and what the cuts will mean, but the stories, because it is data and stories, and it's the kid stories. You know, we've been saying in pediatrics for a long time, the kids sent us. I'm like, no, we brought the kids. Let's bring the kids and the families with us to talk to people in our communities, and not just your federal government representatives. I'm talking about in the coffee shop, at your house of worship, in the pickup line at daycare, in your chamber of commerce meetings, wherever it is. People have to understand how kids in this country are undervalued and how Medicaid is underfunded, and what the implications are for every child in every community if we don't work together to shore it up.
I'm left a little speechless because you really spoke to me there, Sue, about the things we need to be doing, and especially about the importance of narrative and story, which David and I really thrive on that when we podcast. So thank you for that. I feel like we could dedicate this whole episode to Medicaid, but there's so much more to talk about. And one other big issue is the government did attempt to scrub diversity, equity, and inclusion, or DEI, from research. And to tell a little story about that, I had colleagues shaking their heads because diversity in the bacteria they studied was flagged as something related to DEI. Yet we live in a diverse country. Is there any way we can unite over how diverse our children are and the best ways to support them?
Yeah, so I think the important thing is the work must continue. We will only have equitable outcomes for every child. And the premise of the Academy and those of us who are dedicated to taking care of kids is that every kid deserves their best chance of a bright future. And we should do everything we can to do that. And we are have diversity in our population, especially in the child health population. And so we need to work to make that happen. The problem we ran into is triggering language. And triggering language, and when you do, Control F and you find diversity and you say, get rid of everything that matters, there are completely unintended consequences. I'm hoping they're unintended consequences, but I think some of it is because people really don't understand what we're talking about when we're talking about it. So to me, the work is more important than the language. And I want us not to get overburdened by language that is triggering to other people, and find a way to talk about every child matters. What does it mean to create a workforce that looks like the children and families we serve? Because we know that the outcomes are better if they're taken care of by teams that look like them. We trust people who look and think and we have common threads with. And so much of what's happening right now needs to be reinforced in regaining and rebuilding trust, because progress only happens at the speed of trust. And we need to make sure that our families continue to trust in us and our colleagues continue to trust in the leadership so we can get to the important work of advancing child health.
Building on this idea of trust and distrust, I want to talk specifically about our immigrant families. We're seeing reports that they're less likely to visit the pediatrician because of fears of deportation. How can we reach out to and hopefully reassure these parents and their children?
The Academy's hearing this from members all over the country, but it's not the same story in every community. And we are certainly hearing from places where visit numbers have cut in half, which has a whole host of economic considerations, which we could talk about on another show. But more importantly, it means that there are kids who are not getting the care that they need and deserve in the middle of a measles epidemic. So some of that is also vaccination and other important care. It's also, we know, mental health care that these kids need. And so people are getting creative in communities in reaching out to those families. In some places, there are more and more robust telehealth care being provided, and people are going to where the families are, not necessarily having them come in where they are not feeling comfortable and safe. We are trying to uplift people in their clinics so that they know what is legally their responsibility and how to really serve patients well. And in some places, people are being creative in taking vans around to meet families in housing groupings or in other places where families are to meet their needs. So pediatricians around the country are being very creative and innovative in ways to deliver care. And we really need to be proactive about reaching out to those communities. And in many cases, it's their community worker liaisons, right? They may look at us as a threat, but they may not look at somebody in their community who they trust. And so let's figure out how to collaborate with the usual and some additional community trusted voices to make sure that they're getting both the messages that we need them to hear and the care that they need.
And with all this uncertainty, with parents maybe not wanting to come to the pediatrician, do we have any idea how all these changes are influencing parents' mental health?
I don't know that we have data behind it, but we certainly have stories. And we are hearing from families and parents in our clinic that they just don't know. Joanna, you know this, and David, you and I have adult children, right? We've been playing at this a while. It's hard to be a parent. It's hard to be a parent and make decisions on a day-to-day basis for what you hope is the best thing for your child. When you are getting combated with all kinds of messages that are conflicting and uncertain, it feels like an additional weight on your shoulder. And we absolutely know that parents themselves are more anxious and uncertain, and kids look at us to be, and their parents to be the rock and the safe, stable, nurturing relationship. And so what we're encouraging parents to do is go back to those things that you know how to do well. Sit with your child in your lap and read to them. Go for a walk in the park and appreciate the birds and the trees and the beautiful spring flowers. Go back to that relationship building between you and your child. I think it's healing for both the parents who are struggling and the children who are sensing that something is not as rock solid as it used to be. And quite frankly, I think it's healing for us to be talking to families and getting back to that relational health that really is so impactful and important in creating healthy human beings.
So, Sue, you've had a long history of advocating within the AAP. This seems like a moment for advocacy if ever there was one. How can we best advocate for children when we're so concerned about these cuts in spending and how they'll influence their health?
I call myself a fierce advocate for kids and pediatricians. I think the moment requires some ferociousness, and I'm up to the challenge, I guess, if anyone is. But I want everyone to come with me on this journey, right? This is going to take each of us individually, all of us collectively in our organizations, and we have to bring along our communities with us to raise the voice for what children need and deserve. And that means that we need to start talking everywhere. I apologize to my colleagues who are introverts and really want to make this someone else's job. Please just find 3 friends that you don't talk to about healthcare and help them understand that more than half of kids in this country are covered by Medicaid, and cuts to Medicaid won't only impact those kids, but your kids too. Start small and talking in your communities or your Facebook page in your groups or wherever it is, so that we build a groundswell of people all saying, wait a second, the kids are our future. What can we do to make sure that this future is stronger? There are so many levels, including the economic strength of every state, which counts on a strong workforce. Let's talk together and speak up for children using data and stories and taking the children and families with us while we amplify their voice. We are not speaking for our own benefit. We are speaking out on behalf of the kids and families that we're privileged to serve. And so even if this isn't your lane and advocacy is not your thing, it is. You've probably already advocated for prior authorizations or medications for your kids in your exam room. That's advocacy. Start talking outside the medical world in your community and make sure that everyone in your community understands the value of investing in children.
And how do we work to really partner with families to let them know pediatricians remain trustworthy sources of information?
So I think we start by listening. The studies of us interrupting families within 60 seconds or less, I think it's 15 or 20 seconds actually, of when they start talking to us, just start to listen and ask curious questions. How are you doing? Ask them what they need, and then ask them if we could have the privilege of sharing their personal story, either identified or de-identified, with a larger community so that we can help make sure that every single child is seen, is heard, and is valued. And we understand it's a privilege to really make that happen.
Dr. Kressly, do you have any last takeaways about these federal cuts that you can share?
Yes, two. First of all, remember, the people who make policy changes in government are not us, right? But we can influence them. We can influence them. We have knowledge and expertise that they don't have. And we need to make sure that we are really getting our messages to the decision makers and making sure we connect the dots from what policy changes they make that impact the children in our community. And the second is, there's no better time to be a pediatrician because there's so much possible impact that we can have when we raise our voice in our community collectively to change the future for every child.
I am really inspired now. Dr. Sue Kressly, thank you so much for joining us today.
Thanks so much for having me. It's always a pleasure.
To hear more about federal AAP advocacy efforts, visit our website at aap.org/podcast.
Coming up, we'll look at changes in chronic medication dispensing to children and young adults during Medicaid unwinding.
I think it could take a few years to really understand how a major event shapes our lives. Let's take the pandemic. I feel like only recently we have learned the implications of all the uncertainty during that time and just how isolated we all felt.
Yeah, there are still so many things we're learning from and about COVID-19. And if we take the time to reflect, we can hopefully make for a healthier future, one in which we feel more prepared for shifts in healthcare in the United States.
Do you remember, David, the episode we did back in early May 2023 on Medicaid unwinding? Everyone should re-listen to it. But the gist was, because we were coming out of a public health emergency, many children lost access to Medicaid. Unfortunately, with new proposed budget cuts from the Office of Health and Human Services, more children might lose access to their health insurance.
I know that would be awful for children, but unlike the pandemic, where we really knew nothing about the virus, COVID-19, we can and are studying how losing Medicaid is bad for kids. So let's look at one piece of this problem by reviewing the paper, Changes in Chronic Medication Dispensing to Children and Young Adults During Medicaid Unwinding.
The first author on this paper, Dr. Kao-Ping Chua, is back behind the mic to tell us about this study. He has become our go-to person for interrogating prescription databases and joined us on 2 other episodes talking about stimulant and antidepressant prescriptions. As a reminder, he is a primary care pediatrician, associate professor, and health services researcher in the Department of Pediatrics at the University of Michigan School of Medicine. Now he is also director of the Susan B. Meister Child Health Evaluation and Research Center, also in Michigan. Dr. Chua, welcome back to the show.
Thanks for having me.
Before the pandemic started, say January 2020, the Medicaid and Children's Health Insurance Program, or CHIP, covered 35.3 million children. And then, by the time March 2023 rolled around, it was up to 42.3 million. What happened during Medicaid unwinding after the pandemic? How many children lost access?
After states began resuming Medicaid eligibility redeterminations in April 2023, at least 5.5 million children were disenrolled from Medicaid or CHIP.
And was that consistent from one state to another, or were there significant variations?
There was wide variation between states in the number of children that were disenrolled during the Medicaid unwinding process. This is because some states took different approaches than others to implement the unwinding process.
What demographics were the focus of your study?
So in our study, we examined children and young adults separately. Children were defined as individuals aged 0 to 18 years, and young adults were defined as individuals aged 19 to 25 years.
And your study in particular looked at medication dispensing for chronic conditions, both for children and young adults. You chose 5 medication classes. Can you talk about what they were and how you narrowed it down to 5?
We looked at ADHD medications, antidepressants, antiepileptics, antipsychotics, and inhaled steroids. The reason we focused on these medications was because our prior studies had indicated that these are 5 of the most commonly dispensed medications to children and young adults.
And in gathering your data, did you use the same database that you have for other studies when you're looking at prescriptions across the country?
I did. I used something called the IQVIA Longitudinal Prescription Database, which is an all-payer national prescription database that captures approximately 92% of all prescriptions dispensed in the U.S.
So if you happen to be in one of those states with a high disenrollment rate from Medicaid, did you really see a drop in prescription dispensing for children and young adults in these categories?
What we did is we compared changes in medication dispensing among children and young adults who resided in states with high versus low Medicaid enrollment loss during Medicaid unwinding. And what we found is that children and young adults who lived in states experiencing high enrollment loss were more likely to experience disruptions in chronic medication therapy compared to their counterparts in states experiencing lower Medicaid loss.
And what states were the high disenrollment states that you looked at, and which were the low?
Our 2 comparison groups differed depending on whether we were looking at children versus young adults, because we analyzed those 2 groups separately. So when we were looking at children aged 0 to 18 years, the high disenrollment states were Arkansas, Georgia, Iowa, Idaho, Montana, New Hampshire, Oklahoma, South Dakota, Texas, Utah, Wisconsin, and West Virginia. The low disenrollment states were California, Connecticut, District of Columbia, Hawaii, Illinois, Kentucky, Maryland, Maine, North Carolina, Nevada, New York, Rhode Island, and Tennessee. In the young adult analysis, the high disenrollment states were Arkansas, Colorado, Idaho, Kansas, Montana, North Dakota, Oklahoma, Texas, Utah, West Virginia, and Wyoming. The low disenrollment states were California, Connecticut, Delaware, Hawaii, Illinois, Massachusetts, Maine, Nevada, Virginia, and Wisconsin.
And just to put a number on it, what is a high percentage disenrollment in Medicaid?
So when we were looking at children, all of the high disenrollment states experienced a decline in child Medicaid enrollment of 16.9% or more.
And you saw the same thing with the prescriptions?
No, we did not necessarily see a 16.9% decline in prescriptions. So what we found is that among young adults living in states with the highest decline in Medicaid enrollment after unwinding began, discontinuation of medication therapy was more common compared to young adults living in states with the lowest decline in Medicaid enrollment. Young adults living in states with high disenrollment were also more likely to transition to private insurance or cash to pay for their prescriptions, potentially indicating that their out-of-pocket costs had increased. Among children, we saw a similar transition to private insurance or cash to pay for prescriptions. There was a little bit less evidence that children completely stopped taking medications altogether, but there was some evidence that the intensity of use, as measured by the number of days of medication use, decreased in some cases for children. Collectively, our findings suggest that chronic medication therapy was disrupted for many young patients during Medicaid unwinding, and particularly so for young adults.
I don't think this is part of the study, but do we have a sense of what the clinical implications might have been for patients who had to stop and then maybe hopefully restart the medications they were taking?
Unfortunately, our database did not have any information on clinical outcomes, but what we do know from other literature that adherence to chronic medication therapy is very important for preventing disease exacerbations, such as asthma attacks.
And what lessons can we take from this study about Medicaid funding and what might happen if it is universally cut in the United States?
So currently, Congress is debating whether to enact large cuts to Medicaid. And if that occurs, millions of Americans will be rapidly disenrolled, including children and young adults. Our findings suggest that this would result in disruption in chronic medication therapy among many young people, potentially increasing their risk of disease exacerbations and absenteeism from school or work. I think that pediatricians should be aware that these disruptions may occur if Medicaid is cut substantially, and they should work with patients and families to find solutions to minimize these disruptions among young people who lose insurance coverage, for example, including finding lower-cost alternative medications.
Well, Kao-Ping, I am hoping everyone takes something away from your work, not only pediatricians, but also policymakers. If you have one takeaway for us, what would it be?
The takeaway for policymakers is that Medicaid is crucial for children and young adults, particularly so for those with chronic diseases who rely on Medicaid to be able to afford crucial medications. Policymakers really need to do what they can to minimize and perhaps even expand and build upon Medicaid so that all children and young adults with chronic diseases have access to the medications that they need to stay healthy.
Dr. Kao-Ping Chua, thank you so much for joining us today.
Thank you for having me.
To read the paper, Changes in Chronic Medication Dispensing to Children and Young Adults During Medicaid Unwinding, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
All right, Joanna, I feel like I've gotten into a rut of either talking about my children or growing food. This week, I want to talk about my children growing food. So our thyme that we planted is being overtaken by mint. There's not enough to use. But I saw Abby today, who has been inspired by all of my planting and is growing and propagating thyme. And she's like, Dad, I'll just bring you some and you can grow it in a different pot. And I was like, my job here is done.
Can I say, I don't think it's a rut if it brings you joy, David.
Well, it does.
Yes. So I think that you can keep talking about your children and the food that you eat and things that you see. And you forgot that you do a lot of bird stuff too. But so my Say is about none of those things. Is about grandparents. I had a lot of grandparent support on a recent trip that Danny was on. And I just want to take a moment to say that we are just so lucky that our children still have all their grandparents alive and that they are so actively engaged in their caretaking. It brings me so much joy, and I hope that it's that way for years to come.
I'm sure it will be. Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll bring you the last First Up with Dr. Lewis First.
We'll get our usual research roundup, plus a surprise visit or two. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.